I'm Dr. Fakir Ravari, and this is Superiority Randomized Clinical Trials in Pharmacy 515 Biostatistics and Evidence-Based Medicine. Okay, so let's talk about epidemiology in general. Epidemiology is basically the science of counting health-related events in people in relation to population. And there's also the concept of clinical epidemiology, in which the events that they actually count are the clinical events. So things like, mortality, morbidity, hospitalization, and other clinical events. So the content of this topic is organized based on learning objective, and for the exams, the exam questions will be based on learning objectives. So it is important to have the learning objectives in mind when you study for the exam. So the first learning objective is distinguish between various study types such as cohort studies, case control studies, and clinical trials. So generally speaking, there are different types of epidemiological studies. Of course, we can have studies for diagnosis. So these studies, depending on what disease state you're investigating, there are studies that will allow you to come up with accuracy of different test results that are used for diagnosis. They will also tell you things about the tests such as sensitivity, specificity, positive predictive value, and negative predictive value. We will explore these concepts later in the course. We can also have studies for frequency. For example, for a specific disease, you can actually study what's the incidence and prevalence of that particular disease. You can also have study of risk. And this could be like risk for a specific disease, or it can actually be drug related. So like for example, what are risks for having a specific adverse effect for a drug? And of particular, we have cohort studies, and also we have case control studies, which I will actually show you some examples of these. But regardless of what kind of, whether it's cohort study or case control, these can be prospective or retrospective in nature. And I'll explain that in a little bit. We can also have studies of prognosis. So that's basically, what's the, how is someone actually going to recover, depending what it is you're looking, whether it's a disease state or, side effects of a drug. So we can actually have studies for prognosis. And of course, important is studies of treatment. So this is actually where we will study specific drugs. And in general, there are two types of treatment studies. There are observational studies. So when you have observational studies, you're not really intervening. You basically have patients in your study and you just observe them. And then you can actually have experimental studies where you actually intervene with a specific drug and see how the patients respond to that intervention. So observational studies, just like those studies of risk, can be prospective or retrospective. However, experimental studies are usually prospective in nature. And of course, the focus of this topic is clinical trials, so we will focus mostly on clinical trials. There are also studies of prevention, for example, when it comes to vaccination. And also there are studies of cost, so pharmacoeconomic studies also become important. An important concept to understand is the, what we refer to as arms. So Studies can either have one group that they look at, so we typically call them a single arm study, but more commonly we will have two groups, so you can actually compare the two groups and see how they do. And we call these double arm or double group studies. And occasionally you will have more than two groups. So, for example, if you're comparing three drugs, you can have three groups. So each group gets one of the three drugs. And, or more. You can have four groups if you want to. But they're not as common as having the two group studies where, basically two arms are being compared in the study. Now, ideally, in a study, you would like to have a control group. So, a control group is, if depending on the study, some studies are placebo controlled. So, if it's placebo controlled, your control group will receive placebo or inactive drug. Or if it is an active controlled study, your control group will receive active drug. And you might ask, so how do you know between the two? So, for example, if there's a disease that we don't really have a treatment for, and a drug manufacturer is actually trying to bring a new drug to the market, since there is no standard of care, your control group will receive placebo because we don't really have anything to treat it. Whereas if it's established disease where we actually have treatment for, and the manufacturer is trying to bring another drug to the market as an alternative, then it would be unethical to give the control group placebo because we already have treatment for it. In that case, your control group will actually receive active drug, which is the standard of care, and then your other group, which we call the intervention group, will receive the new drug, and you compare it to your control group and see how it does. Of course, if you have a single arm study, you're not going to have a control group, so you just have your intervention group. Occasionally, you can have a single arm study where obviously you have the intervention group, and you can have a historical control group from from other studies that have been done in the past. And sometimes this is being done, for if it's difficult to get a control group, or if the standard of care is not as is not as effective, and your new drug is gonna be a lot more effective than what we have on the market, you can actually rely on that historical group. Now, I mentioned that observational studies and um, cohort studies of risk can be retrospective or prospective in nature. Let's take a look at what that means. So when we talk about retrospective, it basically means that when you start your study, you're actually going to go back in time and look what happened in the past to make, to draw some conclusions. In other words, the patients have already received treatment. They're not even in the hospital anymore. So what you really do is you basically go and study, what the patients received in the past. And depending on what you're comparing, then you draw some conclusions. And this is common because it's easier to do because all you need is access to a electronic medical record, and you can actually go through and collect data. Whereas when we talk about prospective studies, once you start the study, you actually follow patients over time, and then you actually compare the two groups and then draw the conclusions in the future at the end of the study. So this is more expensive because and more difficult because you actually have to follow the patients over time. However, between prospective and retrospective, prospective is the better way to go. Because when you do retrospective is more susceptible to making mistakes or coming up with false conclusions. Whereas when you do a prospective study, you can actually design the study in order to avoid any false conclusions. So that's why when we talk about clinical trials specifically, they are prospective because when a drug manufacturer brings a new drug to the market, they actually design a study, and then they follow patients over time, and then at the end of the study, they figure out how effective the drug is and what are the adverse effects, and then they actually submit the data at the end to the FDA for approval of the drug, which the whole thing will be very expensive, but they have to do it. So as I mentioned, in prospective cohort studies, you basically have your cohort or a group of patients, and then you can, depending on what you're looking at, whether it's a risk factor. For example, what if you wanted to see what's the likelihood of having cardiovascular disease in patients who are smokers. So a risk factor would be a smoker. So what you can do is that you can enroll, let's say you enroll 1,000 patients in your study, and you break them into two groups. You separate the ones that are smokers, so they are exposed to a risk factor, and those who are not smokers, and you follow them over time, and you basically follow them to see at what point they actually develop cardiovascular disease, so yes or no, and then you compare the rate of cardiovascular disease in these two groups, and you can at the end make some conclusions. If the rate was higher in smoking, then you can conclude that smoking is a risk factor that contributes to cardiovascular disease. And this is just an example, so you can apply this to any clinical questions that you want to investigate. So here's an actual example. So this article, impact of reported beta-lactam allergy on inpatient outcomes, which in the title they actually tell you that it's a prospective cohort study. Now, don't worry too much about what they're actually doing. So beta-lactam is a class of antibiotics. So don't really worry about what beta-lactams are. I'm just trying to show you the design of this study. So basically, and here's the abstract of this study, and they tell you that they wanted to do a prospective cohort study, and the outcome that they're looking for is basically readmission for the same infection, acute kidney disease, or some infection. So if you scroll down, usually in the studies you will see a methods section. So if you read the methods section, obviously they have eligibility. So like they tell you what kind of patients will be eligible to be in this study. And then they talk about how the data was collected. So they talk about um, the data collection was done during consultation review rounds on the days they were present for service. So as time went on, they actually collected these data. So that's how this was a prospective. It was done over time. Every time there was a patient consultation, as opposed to going back and reviewing patient charts. So this is a prospective study. And then, of course, they will tell you what they actually found. So the conclusion was avoidance of preferred beta-lactam therapy in patients who report allergies is associated with an increased risk of adverse events. And then you can also have retrospective studies. So case control studies are typically retrospective. So kind of use the same example of cardiovascular disease and smoking. If you were to do a retrospective case control study, basically you identify patients who actually had the disease. So if you actually find patients who had cardiovascular disease, and then you go back in time and look at see if in the past they were smokers or non-smokers. So you actually get the percent, like you can see like what percentage of people who had cardiovascular disease were smokers versus non-smokers. Now, in order to make some clinical conclusions out of this, you actually need to find some case controls. So controls for your cases. So in other words, for every patient that had cardiovascular disease, you're supposed to match them with a patient who did not have cardiovascular disease. And then in these controls patients, you actually go back in time and then you see what percentage of them were smokers or not. And then if you see a difference of rate of smoking between patients who had cardiovascular disease versus who did not, then you can draw some conclusions and see if there's an association between smoking. But this is, so basically you answered the same question, but this method is, going back in time, so it's a retrospective versus the previous one was prospective. Now, when you do case control studies, you can actually, because you have to match it to a control, you basically use risk factors for cardiovascular disease. So for every person that actually had cardiovascular disease, based on age, if you are to find a control for that patient who had cardiovascular disease, you basically try to have someone who's around the same age, same gender, same, any other risk factors that you can find that would contribute to cardiovascular disease. That way, it allows for a better conclusion at the end of the study. Let's take a look at the example. So here's a study, the retrospective cohort of extended infusion piperacillin tazobactam study. Now, don't worry about, piperacillin tazobactam is an antibiotic that's administered intravenously, so it's an IV antibiotic. So don't worry about what piperacillin tazobactam is. I'm just trying to show you the design of this study. So obviously in the title, it actually tells you that it's a retrospective cohort study. So we can actually so again, it tells you the abstract on page 1. But I'm just gonna scroll down to methods section. So they tell you what they did. So this was a multi-center retrospective medical record review. They tell you that it was conducted between this time period. And then they have inclusion criteria. So it tells you what kind of patients were included in the study and who was excluded. And then they have a section for data collection. So they tell you what kind of patient data they collected from the charts. So as you can see, these are all done, from the patient chart. So they didn't actually see the patients. So the patient care has been done in the past. So the patients are not even in the hospital anymore. But you can actually go in there and conduct a study by retrospectively or going back in time and reviewing those patient charts and collecting information in order to answer your question. So, this is an example of a retrospective study. So you need to have a good understanding of the differences between retrospective and prospective studies. The next learning objective is interpret clinical and surrogate endpoints used in clinical studies. Now, clinical endpoints, or sometimes referred to as outcomes, so you can call this clinical outcomes, is basically the occurrence of disease, symptom, sign, or laboratory abnormality that the investigator is actually investigating. So, depends on what the study is actually trying to find. So, for example, if you have a drug and you want to see if it can prevent death, then your primary endpoint or your clinical endpoint will be mortality. Whereas if you want to see if a drug causes bleeding, then your clinical endpoints will be bleeding. So it really depends on what the study is trying to investigate. But regardless, these are referred to as clinical endpoint. Now, the studies will have primary and secondary endpoints. The primary endpoint is what the study is actually designed to investigate. So when we say primary endpoint, that means if the study is designed for it, it's they make sure that anything that can interfere with the true conclusion to be avoided. Whereas with secondary endpoints, these are other things that the study isn't really designed for, but they still look at. And if you do find something, if you find a significant result for secondary endpoint, it gives you clues about doing another study and making that secondary endpoint your primary endpoint. There's also the concept of surrogate endpoint or markers. So generally speaking, clinical endpoints are things that are important to patients and clinicians. So things like mortality. Surrogate endpoints, things that are less important to patients, but they are basically a substitute for those important outcomes. For example, stroke is a clinical endpoint, because if I tell a patient that, a specific drug can reduce the chances of having a stroke, that's important to a patient. Whereas if you have blood pressure as an endpoint, blood pressure is just a number. It may not be as important um, to the patient. But if we use, blood pressure as a substitute for a stroke, and we say that, this drug will lower your blood pressure, which in turn can decrease your chances of having a stroke, then that becomes, meaningful to the patient. So things like blood pressure, when it comes to diabetes, there's a marker we measure called A1C, which basically gives you an idea of how the blood sugar levels are. And when it comes to, for example, cholesterol levels, these are all laboratory values or markers, and these are referred to as surrogate endpoints because if the study is actually measuring these are just numbers. They're not really clinical outcomes, but they are basically a substitute for those outcomes. So, lowering somebody's cholesterol has a meaning. Even though we're not actually measuring mortality, we can actually say that, this is a substitute for chances of having mortality. There's also the concept of composite endpoint. So typically, uh, studies can actually have several variables as the primary endpoint. So for example, they can say that the primary endpoint is a composite endpoint of death, heart attack, or hospitalization. So if they include all three of them in one endpoint, we call that a composite endpoint. And the reason they would do that is because if you have multiple things that you're looking for as your outcome, it becomes easier to find it. And the reason they do that is because in the past 2 decades, because of the advancements in medical care, it's actually more difficult to find clinical outcomes like death. Just because our standard of care has improved so much that if you're really trying to prove that your drug can reduce the rate of mortality, it becomes difficult. And in fact, you actually need a large sample size and a long follow-up, and sometimes it becomes impossible to find it. And that has led, investigators to come up with composite endpoints to help being able to actually conduct a clinical study and find a significant result. Now let's take a look at an example. So this is from the syntax trial. Again, I'm just trying to show you the design of the study, so don't worry too much about what they actually did. So this is an example of a two-arm study. So there are two groups. So two groups, right? One is a control group and one is an intervention group. So CABG or CABG. So CABG is basically a surgical intervention for people who, let's say, have a heart attack, and PCI or percutaneous coronary intervention is a less invasive way of dealing with a heart attack. So both of them are, surgical. I'm sorry. One is surgical. One is a less invasive intervention for dealing with heart failure. Regardless, what I'm trying to say is that there are no drugs involved here. So regardless of which group you have, the primary endpoint you're looking at is a composite endpoint um, of death, stroke, MI, or revascularization. And then they tell you like, if the primary endpoint, how many times did it happen in. So you can see that the rate of the primary endpoint was 17.8% in the intervention group and 12.2% in the control group. Okay, so the rate was actually higher in the intervention group. So what you can do is that you can actually calculate the difference between. So basically 17.8 minus 12.4 will give you 5.4. So the difference between the two groups is 5.4%. And they will tell you also a 95% confidence interval. So in this study, they found that the rate of the primary endpoint was 17.8% in intervention group and 12.4% in the control group, and the difference between the two groups was 5.4%. And this difference is what they found in this study. So the 95% confidence interval tells you that, if you were to do this study again, there's a 95% chance that that difference would be between 2.13 to 8.83%. Because if you do this study again, you're not going to find exactly 5.4 again. So basically, they're telling you what are the odds of, or what are the chances of, having something similar to 5.4. And that's what the confidence interval is. And they will also calculate the relative risk. Now, don't worry about how to calculate these numbers. We will actually do calculations later in the course. What you should do right now is to understand how to interpret these numbers. So a risk difference of positive 5.4 means that you actually increase the events, the primary endpoint events in your intervention group. Whereas if it was a negative number, that means you actually reduced the number of those events in your intervention group. Now with the relative risk, because this number, the 5.4, this is absolute risk difference. So this is, the absolute difference between 17.8 and 12.4 is 5.4. You can also calculate a relative risk. So relatively speaking, 1.44 is the relative risk between, so there was actually a 44% risk increase. And again, they will give you a 95% confidence interval. Now, what's really important is the p-value, because we found the difference between the two groups. Obviously, 17.8 is different than 12.4. So when you find the difference between the two groups, the question is this a true difference or is it a chance finding? And you will look at the p-value, and because the p-value is less than 0.05 or less than 5%, we know that this is not a chance finding. So we call this a statistically significant difference. So because the p-value is small, this is not a chance finding, and this difference is statistically significant. Now, when you look at, that was a composite, so that means that included, when you have one composite endpoint, that means it's either death or stroke or MI or subsequent revascularization. So the question is, which one did it actually increase? So death is particularly important. So when you look at number of deaths in each group, you can see that there was the rate of death in the intervention group was 4.4%, versus in control group the rate was 3.5%. And if you calculate the difference, so 4.4 minus 3.5 will give you 0.9. So because there, obviously there's a difference. So 4.4 is different than 3.5. So if you look at the p-value, this time the p-value is not small. So although 4.4 and 3.5 are different, because the p-value is large, in fact, there's a 37% chance that this is a chance finding. This difference is a chance finding. Because of that, we say that there is no statistically significant difference between the two groups. In other words, the rates of death is not different between the two groups. And that's because the p-value is large. The same is true with MI. So when you look at the rate of MI, obviously 4.8 and 3.3 are different. But because the p-value is large, we say this is not statistically significant. Therefore, there is no difference between the two groups when it comes to the rate of MI. When you look at stroke, the p-value is small, so there is a statistically significant difference between the two groups in regards to rate of stroke. So absolute risk is the risk of having your endpoint in each group. And then once you have your absolute risk, as we saw in the previous page, then you can actually calculate the difference. So if the difference is a negative number, that means your intervention actually decreased the risk. So we call this an absolute risk reduction. Whereas if the difference is a positive number, that means you actually increased the risk. So this is an absolute risk increase. And if the difference is 0, that means there's really no difference between the two groups. You basically subtracted the same number, and that's how you would get 0. And of course, there's also relative risk. With relative risk or risk ratio, because it's a ratio, if you have the same numbers in the ratio, you would get 1. So 1 would mean no difference between the two groups. Whereas and usually we have the intervention in the numerator and your control in the denominator. So if there are less events in your intervention, that means your ratio will be less than 1. So that would result in a relative risk reduction. Versus if the number of events in your intervention is more than your control group, then the ratio would be greater than 1. So that would be a relative risk increase. I will show you visually what these numbers really mean in a little bit. Now, hazard ratio is also a ratio, and it's similar to relative risk. The only difference is that when you calculate relative risk, it's actually done at a specific time point in the study, typically at the end of the study. And when it comes to mortality, for example, that's something that you would like to know over time. So because there's this component of time, the calculations is more complicated. So it's not as easy as the way that we calculate relative risk. And typically statistical software is used to calculate hazard ratio. However, because it's a ratio, you actually interpret it the exact same way that you would interpret relative risk. One method that you will see in a lot of studies, the Kaplan-Meier curves, that actually uses hazard ratios and looks at survival curves. And you will see examples of Kaplan-Meier curves in a lot of clinical trials. The last thing that you need to know in order to interpret the results of endpoints in randomized clinical trials is the concept of number needed to treat, which is basically the number of patients you would need to treat for the duration of the study follow-up in order to prevent one adverse effect or whatever the endpoint for that particular study was. And the way we actually calculate number needed to treat is that 100 divided by absolute risk reduction. Now let's take a look at some examples. So let's say these are just hypothetical numbers. So let's say there's a study looking at the rate of mortality between the two groups. So you have your intervention group and your control group. So let's say we're looking at mortality, and the rate of mortality is 1% in your intervention group and 2% in your control group. So 1 divided by 2 will give you 0.5, and that's your relative risk. And 0.5 would mean there's a 50% relative risk reduction. So basically, 1 minus 0.5 equals 0.5, which means 50% relative risk reduction. And in order to get absolute risk reduction, basically, if you went from 2% to 1%, that means you had, 2 minus 1 is 1% absolute risk reduction. And the way you calculate number needed to treat is 100 divided by 1, which is 100. So you would have to treat 100 patients for the duration of how. So let's say this study followed patients for 5 years. So this means that you would have to treat 100 patients for 5 years in order to prevent one death in patient, if the patient received intervention as opposed to control. So that's how you interpret number needed to treat. Now let's take a look at another example. Let's say, again, we're looking at mortality. Let's say the rate of mortality was 20% in your intervention group, and the rate of mortality was 40% in your control group. Again, relative risk is the same number, 0.5, because 20 divided by 40 will give you 0.5. Which shows you like the danger of using, relying on relative risk, because even though, these numbers are the same between those two studies, these rates are extremely different. So again, relative risk of 0.5, so 1 minus 0.5 is 0.5, or 50% relative risk reduction. However, now look at the absolute risk reduction. So if we went from 40% to 20%, so 40 minus 20 is 20%, and 100 divided by 20 is 5. So now the number needed to treat is 5. So you basically need to treat 5 patients for 5 years in order to prevent one death. So that's a lot more significant than 100. So generally speaking, a number needed to treat of around 50 or less is considered significant, whereas a number needed to treat of 100 or more, is not very significant. And between 50 and 100 is a gray area where you would have to use your clinical judgment. Here's another example. So let's say the rate of mortality was 3% in intervention group and 4% in the control group. Now 3 divided by 4 will give you a relative risk of 0.75, and 1 minus 0.75 is 0.25, which means that there was a 25% relative risk reduction. Now, in order to get absolute risk reduction, if you went from 4% in your control group to 3% in intervention group, that means 4 minus 3 is 1, so we had 1% absolute risk reduction. And again, 100 divided by 1 will give you a number needed to treat of 100. There are some other examples that you can look at on your own in this table. The next learning objective is describe superiority randomized clinical trials. Now, every time a new drug comes to the market, the drug manufacturer needs to go through a series of clinical trials. Of course, before they actually start studying the drug in humans, they will do some preclinical studies. So this all starts, actually in the lab, like bench side research. So, that's how they come up with the actual chemical, and they do some drug discovery. And once they come up with a drug that they think would be effective for a specific disease, the next step would be to do some animal studies to make sure that for example, the drug doesn't kill that animal before they go and study it in humans. So once they go through preclinical studies, which would take several years, the next step is phase 1 studies. So in phase 1 studies, which is a small study, because it's the first time they're going to study this is in humans, they actually studied in young, healthy people. So they actually do not have the disease. So whatever the drugs, so let's say we're bringing a new drug for hypertension. They will actually bring volunteers who do not have hypertension, and they will give them this drug. And these are volunteers who actually get paid to be in phase 1 studies. And the purpose of that is to ensure that their drug is safe. So they're not trying to see if it's effective. They just want to make sure it's safe. They want to make sure that nobody dies. Of course, when it comes to death, they have already tried it on animals to make sure it doesn't kill animals. But regardless, you also want to make sure it's not you cannot assume that just because the drug didn't kill the animals, it's not going to kill people. So that would be of interest. That's why these studies are small. So you don't want to bring like 5,000 people in the study, and if it ends up harming a lot of people. So these are healthy volunteers, and you basically look for adverse effects and safety. Once they establish safety here, then they go to phase two. And phase two trials are, bigger than phase one, but still they're not as big. So now they actually bring people with the disease. So they will actually enroll patients with hypertension, and they will give them the drug. And typically at this stage, they also look for a safe dose. So they may be trying different doses to make sure that they get the dose that's safe and effective. And once they figure out that it's safe and effective, and they figure out the dose, that's where you go to phase three. And majority of studies that you will see in the literature are phase three randomized control trials, randomized clinical trials. So, and that's where you start to get as many patients as you can. So as many patients as you can, that's feasible for the duration of study. And you actually want to show efficacy and safety at the same time. And once phase three is done, that's where they would apply to FDA for approval, and FDA will analyze phase three trials results, as well as all the other previous studies they've done so far, and collectively together the FDA will decide if the drug is safe and effective, and they will approve it. And once the drug is on the market, of course, there will be like phase four studies going on, and that's to make sure that occasionally there are adverse effects that you cannot detect in phase three studies because they're not long enough. Phase 4 studies will allow a longer time and a much larger population in order to find very rare adverse effects for the drug. But majority of studies that you will see will be phase 3 trials. Now, generally speaking, when it comes to randomized clinical trials, there are three different types. So one, which is the topic of today, is superiority trials. Basically, they want to show that treatment is more effective compared to your control group. And they usually do this if, when you really don't have a good treatment for a disease, or if you don't have a treatment. So, if there is no treatment, you basically want to show superiority to placebo. And if there is a treatment available and you want to show that there's something better, then you'll do a superiority. Something that we will talk about after the block exam, so in 2 weeks, is non-inferiority, which is basically if you just want to bring a drug that's an alternative to the current standard of care. And then lastly, the equivalent studies that you will almost never see, because they're basically used for every time there's a generic that comes to the market. They have to do equivalent studies to show the FDA that the generic is equivalent to the brand. So they're obviously very important, but they're not, they're typically not published in the literature, because it's just really about generic drugs showing the FDA that it's equivalent. So let's say your clinical trial is looking at patient's blood pressure. So let's say you find somebody's blood pressure and it goes here, and then you do it again and it's something here, and you do it again and it goes here, and you do it again and it goes here, and you do it again and it goes here, you do it again, it goes here, do it again, it goes here. So if you keep repeating your measurements for blood pressure, you start to get a distribution. So that's what we mean by distribution. So occasionally you have outliers that are far from the center of tendency for this, but like at the end of it, what you get is that you get the mean. So there's a mean for the distribution, and then away from the mean you have your standard deviation. So a standard deviation, so you can see this is one standard deviation, plus or minus, and then you have two standard deviations plus or minus away from the mean of your distribution, and up to three, right? And then you can see that so one standard deviation away from your mean captures 68% of the distribution. So this right here is 68% of the distribution. Versus if you do two standard deviations from your mean, so plus minus 2 will capture 95% of the distribution. So that's a significant number because we are interested in 95% of the distribution, and we think that's clinically significant because that's within two standard deviation that captures 95%. So anything that's outside of the two standard deviation, it could be considered outlier. So that could be like a chance finding. And I'll explain that in a little more detail. But the reason, so one specific thing about normal distribution is that because it's symmetric, so your mean, median, and mode will be on the same line. So that's your center of tendency for the distribution. Whereas things that are not normally distributed, you can see that mean, median, and mode do not lie on the same line. So you can see this either negatively skewed or positively skewed as the data tend to go to left or right. And these are more complicated to interpret. So that's why for simplicity, we're just going to talk about normal distribution. So when it comes to interpreting superiority randomized clinical trials, you will hear the concept of two-sided significance level. So as I mentioned, we're interested in 95% of the distribution. So 95% is within two standard deviations from the mean. So here's our center of tendency, and we're interested in 95%. So it's common to see a 95% confidence interval, and the way you calculate confidence interval is that it's equals to 1 minus alpha, and alpha is your significance level. So as if you remember, when you interpret p-values, you need to know your alpha, because a p-value is significant if it's less than your alpha. And what we typically do in in randomized clinical trials is that we commonly use a 5% alpha or an alpha of 0.05, and that's why 1 minus 0.05 equals 0.95 or 95%. So anytime you have a alpha of 5%, you need to have a confidence interval of 95% so that it follows this rule for confidence interval. Now you will so what this means is that obviously mu is the center of tendency or the mean of your distribution, and so anytime you do an experiment, what you find in that study is your mean. And if you were to do that study again, chances are that you will not find the exact same thing. So if you do it again, it might be something different. And what we really mean here is that if you do the study again, we are 95% confident that it will be something between within two standard deviations. So anything outside of that might be considered a chance finding, and that's why if you remember the concept of type 1 error, so type 1 error means like a false positive. It can either be on this side or this side, and that's what we mean by two-sided. So it's a matter of whether it deviates from your finding to the right or to the left. So we allow like 2.5% type 1 error on this side and a 2.5% error on this side, and together we call this a two-sided or two-tailed. You may hear the concept two-tailed and two-sided. It means the same thing. Uh, two-tailed significance level of 5%. And superiority randomized control trials will always use a two-tailed significance level, whereas when we talk about non-inferiority trials, you'll see that they will use a one-sided or one-tailed significance level. Now, just to give you another example of this equation, so if someone was to use a alpha of 2%, so if they use the two-sided alpha of 2%, then they will have to use a 98% confidence interval. Because if you use a 95% confidence interval with this, with an alpha of 2%, then that's a violation of this equation. So if you catch that in a randomized clinical trial, that should be a criticism of that study. Now let's look at some real example. So here I'm showing you the Charisma trial that was published in New England Journal of Medicine in 2006. So what they're doing is that so here are your two groups. The control group received placebo plus aspirin, versus the intervention group received clopidogrel and aspirin. Now don't worry about these drugs. I'm just trying to show you the design of the study and how to interpret the results. So the primary endpoint in this study was actually a composite of myocardial infarction, stroke, or death from cardiovascular causes. And you can see that so the rate of this endpoint was 6.8% in the intervention group and 7.3% in the placebo group. And they actually calculated a relative risk of 0.93. And they give you a 95% confidence interval that goes from 0.83 to 1.05. And they give you a p-value of 0.22. Okay? So obviously 6.8 is different than 7.3. The numbers are different. However, if you look at the p-value, because the p-value is less than the alpha, which is 5%, this is not statistically significant. So there is no statistically significant difference between these two groups. Which brings me to an important point. You should never calculate absolute risk reduction or number needed to treat if there is no statistically significant difference. So you should not calculate. So don't say 7.3 minus 6.8 would be your absolute risk reduction. You should not do it because it's not statistically significant. It would be meaningless to calculate absolute risk reduction and number needed to treat when there is no statistically significant difference. Now, the way they calculate relative risk or risk ratio, it's a ratio of your intervention group and your control group. So because it's a ratio, it's a matter of, how many events happened in each group. So that helps you understand, so obviously here, more events happened in the control group. So 573 is larger than 534. So which means that you're dividing a smaller number by a larger number. So obviously this will give you a number that's less than 1. So if your number is less than 1, so like 0.93, so 0.93 is less than 1, that means it's actually in favor of your intervention group. So your intervention is doing better. Okay. Now, if these numbers were reversed, that means that would have meant that your control group was doing better. So if the number was greater than 1, and obviously if you had the same number of events in both groups, you're dividing the same number, which means that you would get actually 1. 1 means there would be no difference, absolutely no difference between the two groups. Okay, so 0.93 means in favor of intervention group. The problem is that 0.93 is what they actually found in that study. If they were to do that study again, they're not going to get exactly the same 0.93. In fact, there's a 95% chance that it would be something between 0.83 all the way to 1.05, and that's what they told you. So when they tell you confidence interval 0.83 to 1.09, that's what they're really trying to tell you here. If you do this again, 95% chance that it would be something within 2 standard deviation of 0.93. The problem is, what if it's, what if you do it again and it's 1? If it's 1, 1 means no difference. 1 means no difference, so how are you going to interpret that? Or what if it's greater than 1? What if it's 1.04 or 1.05? Now it means your control group is different. And that's why we call this, anytime you're talking about the ratio, we call 1 the line of unity or line of no difference. And when it comes to superiority, if your confidence interval crosses this line or even touches it, if it touches the line, it loses statistical significance. So if you did not have this p-value, if you didn't have it, all you had to do is look at this confidence interval, and then you can say that, well, because it crossed 1, I know it's not statistically significant. So sometimes they may not even give you this p-value, and you don't even need it. All you have to do is read the confidence interval and conclude that because it crossed 1, it is not statistically significant. Now, if it didn't cross 1 and it was, less than 1 on this side, that would mean that intervention group is better. Or if the whole thing was on the other side, greater than 1, it would actually mean that your control group is doing better than your intervention group. So that's how you interpret relative risk. When it comes to hazard ratio, as I mentioned, hazard ratio is also a ratio, so it's a ratio of intervention to control. Now it's a little more complicated than this when they actually calculate it, but in order to be able to interpret it, all you have to keep in mind is that it's just a ratio. So you interpret it the same way. If it's less than 1, intervention group is better, or if it's greater than 1, your control group is better. And again, you have 1 as your line of unity or line of no difference. Now, in this example, which is from the sprint trial, they were comparing 2 different strategies for blood pressure management. Now, don't worry about what those strategies were. Just know that here's a intervention group and here's a control group. And they were looking at the primary endpoint. Don't worry about what those endpoints are, but look at the rate. So for that primary endpoint, the rate of the event was 5.2% in the intervention compared to 6.8% in the control group. So obviously 5.2 and 6.8 are different. The question is this is this a statistically significant difference? So when you look at the hazard ratio is 0.75. So obviously it's less than 1, so it's in favor of your intervention group. And then they give you a 95% confidence interval. So it goes from 0.64, so 0.64 all the way to 0.89. So here's a 90. So in other words, the hazard ratio in the sprint trial was 0.75, which means that there was a 25% reduction in hazard. So that's what they found in this study. And if they were to do the sprint trial again, they're not going to find exactly 0.75 anymore. But we're 95% sure that if you do it again, it's going to be something between 0.64 and 0.89. And because this confidence interval did not touch or cross 1, that's how we know it's statistically significant. It is statistically significant. So there is truly a difference between 5.2 and 6.8, which is consistent with the p-value. So if you were to look at the p-value, it's less than 5%. So the alpha is 5% for the study. So because it's less than that, it's statistically significant. So you don't really need the p-value. You could really just look at the confidence interval and decide if it's statistically significant or not. And because it is statistically significant, Now it's okay to calculate absolute risk reduction and number needed to treat. So 6.8 minus 5.2 will give you 1.6, and 100 divided 1.6 give you 63. So you would have to treat 63 patients um, with the intensive treatment in order to avoid one of these primary endpoints. So, don't worry about sprint trial, but be able to interpret these numbers. Now, those are so far we talked about ratios. There's also the concept of difference. So this is the Cantana SU trial that looked at two anti-diabetic agents. Now, don't worry about these drugs, just understand the design of the study. So this is your intervention group and this is your control group, and they really wanted to see the effect of these drugs on change in body weight from baseline. So they actually found that in the intervention group, patients on average, actually by the end of the study, they lost 3.7 kilos. Whereas in the control group, they actually gained 0.7 kilograms. So obviously these two numbers are different. So instead of a ratio, and this is so the reason they're doing difference rather than ratio is that these are not clinical endpoints. These are actually surrogates. So this is this is just a number, body weight. So it's a surrogate for, like you can talk about like, losing weight can have, reduce your chances of, heart attack, for example. So it's a substitute for a more clinical, meaningful outcomes. So because it's a surrogate, we're not going to calculate the ratio. We're just going to calculate the absolute difference. So you know, so the way we calculate the difference is that it's your intervention minus control. So negative 3.7 minus zero point 0.7 is equals to negative 4.4. So the difference between the two groups was negative 4.4 kilogram. Now they actually gave you a 95% confidence interval. So this difference between the change in weight in between the two groups in this study was negative 4.4 kilogram. And if you were to do this again, there's a 95% chance that it could be something between negative 4.8 and negative 3.9. The question is, how do you interpret the, since it's not a ratio, how do you interpret the confidence interval to know if it's statistically significant? So because you're looking at the difference, if the number of event is larger in your control group, you're going to end up with a negative number, which means that your intervention group is doing better. Whereas if the number in your intervention group is larger, then the difference will be a positive number or greater than 0, which means that your control group is doing better. And if you have the same number in both groups, obviously you're subtracting the same number, so you will get 0. So if the difference is 0, that means no difference. Which means that instead of 1, we're dealing with the 0. Before it was a ratio, so we had to deal with 1. But now, because we're looking at difference, we have to deal with 0. So really the line of unity or line of no difference is 0 now. So you do not want the confidence interval to touch or cross 0. So when you read confidence interval for difference, if it's from a negative number to a negative number, that means it didn't cross 0. For example, if it goes from a negative number to a positive number, that's how you know it crossed 0. So in this case, because it did not cross 0, you will say that it is statistically significant, which is consistent with the p-value. So if you look at the p-value is less than 5%, which is your alpha, so you can say that it's statistically significant. Now, this is statistically significant. However, because this is a surrogate endpoint dealing with difference, it doesn't really, it has no meaning to calculate number needed to treat or absolute risk reduction. I suppose if you wanted to see how many patients you had to treat in order to lose 1 kilogram, you could, but it really has no clinical meaning. The next learning objective is identify different types of bias and random error encountered in clinical research. Now, obviously, anytime that the clinical study is done, we're looking for some truth. The problem is it's almost impossible to find the absolute truth. There will always be some deviation from the truth. Now, generally speaking, there are two types of errors that will occur in studies. One is due to chance alone, which we call this random error. And one is systematic error that we call bias. And both of these are important to consider anytime you evaluate clinical trials. So let's say that we're doing an experiment to measure somebody's blood pressure. If you could actually measure the true blood pressure from intra-arterial cannula, and let's say it's around 80, let's say that's the true diastolic blood pressure. And then we're going to use a device, a non-invasive device, to actually calculate it. So because the device can have systematic error, so there will be some bias just because of the device. So it would, let's say, it will give you a diastolic of 90, and that's some deviation from the truth. And then within that, chance alone. So if you were to use the same device multiple times, you will get like different numbers, and then you kind of get that distribution again. So that also is due to chance. So you have to deal with chance and bias when you do experiments. And it's important to be able to evaluate these in clinical trials. So there are different types of bias. One type of bias is confounding bias, which basically is when different factors can actually distort the effect of other variables. Most of these are pretty self-explanatory. Pay particular attention to measurement bias and also selection bias. And the way that we can actually reduce bias in clinical studies are, so it's a matter of when during the study. So there are things you can do at the start of the study, and then things during the study, and then things at the completion of the study. So the reason we have the concept of randomized clinical trial is to in order to prevent some of these biases. So randomization occurs at the beginning of the study, and then the concept of blinding that needs to exist during the study. And of course, at the completion of the study, you don't want to lose patients to follow up in order to avoid other sources of bias. The next learning objective is differentiate between intention to treat and per protocol analysis. So when it comes to dropouts in clinical trials, it's typically due to two reasons. One is because of non-adherence. So someone just doesn't wish to be in the study anymore, and one is basically loss to follow up. So whether the patient moved away or something happened to them. So the concept of intention to treat principle basically says that you have to count events in all randomized patients, regardless of whether they received the intended intervention. So let's say if we wanted to study a new drug for 5 years, the intention to treat would basically say that if someone was enrolled in the study because we intended to treat them, even if they didn't take any of the drugs for the 5 years, you still include them as part of the analysis because you intended to treat them, even though you didn't. We will include them in the intention to treat analysis. And as opposed to per protocol analysis. So per protocol, that means you have to follow the protocol. So if the study has a protocol and says you have to take this drug once a day for 5 years, you have to follow that protocol. So if you violated the protocol, then you're not included in the per protocol analysis. So generally speaking, if you do per protocol, a lot of people would think that per protocol is the way to go, because if you really want to know if a drug works or not, you want them to, follow the protocol. But this is dangerous because removing patients after randomization can actually introduce risk of bias, which is what randomization was trying to actually prevent. So generally speaking, it's actually a good idea to have intention to treat because it's actually uh, more representative of the real world. So in the real world, when you send patients home with the medication, you're not there to make sure that they follow the protocol. So occasionally patients miss a dose or two. So if you actually prove benefit with the intention to treat analysis, you're actually more confident that the results will actually be true in your patient. Now, there are situations where per protocol is actually preferred. For example, if if your study is trying to evaluate toxicity, for example, if you actually want to show what's the adverse effects of the drug, if somebody didn't take the drug and you include that in your analysis and say, look, the rate of adverse effect was really, really low, and that's not good. So it's really, for that purpose, you really want to use per protocol. But other than these unusual situations, generally speaking, intention to treat is the preferred method in order to reduce the risk of bias. Let's take a look at an example. Let's say we were doing a study for cerebrovascular disease, or let's just call this stroke. So let's say we had patients with stroke and we randomized them to two groups. One group just received aspirin and the other group received aspirin plus surgery. Okay. So, and then, by the way, the surgery is scheduled a month from randomization. And the outcome that we're measuring is just how many patients are going to have stroke. Okay, another stroke, that is. So let's say, obviously, both groups received aspirin, and within a month, let's say the rate of stroke, even with aspirin, is 10%. So of 100, and let's say there are 100 patients in this group and 100 patients in this group, and within a month, 10 patients will have stroke. So the rate of stroke is equal. And the reason it's equal in both groups because we randomized. We randomized, so both groups should ideally have the same prognosis for stroke. So if the two groups are equal, within 1 month, they should have the same rate of stroke, which is what this is showing. Now, at 1 month point, the group that also has surgery is going to perform surgery. Okay. The problem is those patients who had stroke, those 10%, they may not make it to the surgery anymore. So, and then at the end, let's say the rate of stroke was still 10%. In other words, let's say surgery makes no difference. If the surgery makes no difference, even after the surgery, the rate of stroke is still 10% and 10%. Now let's take a look at if we do intention to treat analysis or per protocol analysis and if it makes a difference. If we do intention to treat, so in the surgery group, by the end of it, let's say 20 people out of 100 had stroke. So the rate is 20%, right? The same is true in the group that only received aspirin. So 20 people had stroke by the end of the study. So 20 out of 100. So the rate is 20%, which means that the difference, so 0.2 divided by 0.2 is 1. So relative risk is 1. In order to calculate relative risk reduction, so 1 minus 1 is 0. So relative risk reduction is 0. In other words, there's really no difference if you use the intention to treat. So that's why intention to treat is the way to go. Now, if you were to do the per protocol analysis on this study, you would say, well, these 10% is, or I should say, these 10 patients who had stroke and didn't go surgery, they violated the protocol because they didn't undergo surgery. So we're only going to look at the patients who underwent surgery. So at this point, because these 10 patients had stroke, there's only 90 left. So 90 patients will go through surgery, and 10 of those 90 will have stroke. So 10 out of 90 will give you a rate of 0.11. And of course, nothing changes in the other group, so you still have the 0.20. This will give you a relative risk of 0.55, so a relative risk reduction of 0.45. And that's a huge difference. So now if you do the per protocol, you're claiming that that surgery actually reduced the rate of stroke by 45%, which we know is not true. So that's the importance of having intention to treat, because per protocol will introduce bias towards the um, uh, which will deviate from the truth, which we know in this hypothetical example was that surgery makes no difference. The last learning objective is critically appraise randomized clinical trials. So when you have a randomized clinical trial, the first thing that you need to look at is the risk of bias. And we call this internal validity. So internal validity deals with, was the study valid? Did they have a sound study design, and did they do everything they were supposed to do in order to avoid the risk of bias? And here are 10 questions that you should ask when you evaluate internal validity for a randomized clinical trial. And these are from JAMA Evidence. So JAMA is the Journal of American Medical Association, and they have these JAMA Evidence series that are a huge part of evidence-based medicine. So of course, the first question evaluates did we avoid the risk of bias at the start of the study. So one thing that's really important is randomization. So we need to make sure. So obviously, if we're talking about randomized clinical trial, you will have to make sure, because some studies can claim that they're randomized, but they actually we need to evaluate and what process did they use to randomize the patients. So if the study is randomized, we have to make sure that the randomization process was concealed. And what that means is that, those who actually enroll patients should be unaware and not be able to decide which arm the patients are getting allocated to. And then once the patients are randomized to the two groups, we have to make sure that the two groups are actually pretty similar. So anytime you look at the randomized clinical trial, usually you will be provided with a table in the study or in the article that's referred to as baseline characteristics. So in those baseline characteristics, you basically should look for risk factors that are of prognostic value, and make sure that those values are similar between the two groups. And if the randomization is done correctly, they are typically equal between the two groups. So that was at the beginning. So once the study has actually started, we have to make sure that the balance between the two groups is maintained during the study. And that's how blinding comes in, or sometimes referred to as masking. So the best way to do it is by doing a double blind. Of course, sometimes studies are not blinded, so we refer to studies that are not blinded as open label. Um, but blinding can be single blind, double, or double blind. So single blind means only one of the three categories of individuals are blinded. So either the patients or participants or the investigators or people who actually do the analysis. Double blind means everybody has been blinded, so nobody knows what treatment the patients are getting, um, you know. And there's also the concept of double dummy. So double dummy. So if a study is double blind, sometimes it becomes difficult to maintain the blinding. So let's say we have two groups. We are comparing two drugs between the two groups. If one drug is oral, so let's say it's a tablet, and the other group is getting something that's intravenously, so we have to do IV infusion. There's no, how can you blind it? It it's become easy for the patients to figure out what they're getting. So that's where the concept of double dummy comes in. That's where, like, so we will give both groups a placebo for the other treatment. So for example, if one group was supposed to get a drug tablet, we will give them the tablet, and then we will also give them a placebo for the IV infusion that the other group is getting. And then the other group that was supposed to get the IV drug, we'll give them the IV drug. And in addition, we also give them a placebo for the tablet that the other group is getting. So this concept is referred to as double dummy, and that's in order to be able to maintain blinding. And then at the end of the study, you still want to make sure that the two groups are balanced. So you want to make sure that the follow-up was completed, and you want to make sure that the study was not stopped early, because if any of these happened, that's potential for introduction of bias. So when you lose patients to follow up, it can make a big difference, because the question is, if you lost someone to follow up, you don't know if they died, for example, or if they're just not, available anymore. So let's consider two different trials. So trial A and trial B. Let's say these are basically identical trials with 1,000 patients in each group, and the same rate of loss to follow up. Loss to follow up was 3% in all arms. So equal amount of loss to follow up, just 30 patients out of 1,000 in each group. Now, if the primary endpoint was death in both studies, and let's say 200 people died in treatment group from trial A, and twice as many, 400 in the control group, that gives you 20% and 40%. And then in trial B, let's say 30 patients died in the treatment group and 60 patients in the control group, so twice as many, but so twice as many in the control group, but the percentage is a lot smaller, so 3% and 6%. Okay. Now, when you do the relative risk reduction, obviously, if you ignore the loss to follow up, because both of these doubled, the relative risk reduction is 50%. So in both studies, we showed that the rate of mortality was reduced by the treatment by 50%. Now, if we assume the worst case scenario and assume that people who were lost to follow up actually died, and take that into consideration, then you can see that relative risk reduction would change. In a study where a lot of people died, it doesn't really make a difference, because that 30 lost to follow-up is insignificant compared to 200 people who died. So, it changed the relative risk reduction only slightly. Whereas in a study where the rate of mortality was smaller, so 30 people died, if you also consider the 30 patients lost to follow-up, suddenly you double the number of patients who died, and it actually changed the number significantly. So now you're showing a relative risk reduction of close to 0. So it made a huge difference. So that's why it's important to consider when patients are lost to follow-up. And the way you do that is that you basically consider the worst case scenario to see if it makes a difference. And we call these sensitivity analysis. So once we make sure that the study had good internal validity, then we can actually look at the results and see the treatment effect. One thing that's important is we need to know how precise was the estimate of the treatment effect. And when we do this, we also look at the confidence interval. So here are two examples. So let's say we have study A and study B. And in study A, there are 100 patients in each group. So study A is the wider uh, distribution curve. And whereas in study B, we have 1,000 patients per group. Okay, so let's say both studies found the same relative risk reduction of 25%. So the same, uh, but you can see that in study A, the confidence interval is huge. In fact, it actually loses statistical significance because it crosses zero, even though they have the same value for relative risk reduction. Whereas the study B, that was a larger study, um, had a confidence interval that did not cross zero, so it actually gained statistical significance. So the point of this is that the larger the study, the more the narrower the confidence interval. So sometimes when studies are small and the confidence interval crosses the line of no difference, then the question becomes: was the study large enough? So you would have to enroll more patients in order to have a sufficient sample size in order to have a narrower confidence interval, which kind of tells you. So like in other words, the higher the number of patients, the more precise the results will be. And the last thing that we'll have to consider is how can you apply the results to your patient? And this is referred to as external validity. So external validity basically is asking how generalizable are the results and can you apply it to your patients. So you want to see how similar the patients are to your patients. So that's where you look at inclusion and exclusion criteria um, in the studies. But really, more importantly, is can you find compelling reasons uh, uh, in which you cannot generalize the results to your patients? Because if you cannot find a compelling reason, it's typically generalizable to your patient. One common example is renal function. A lot of drugs are renally cleared, and a lot of studies exclude patients with renal dysfunction. So if you find that a study excluded certain patients with renal dysfunction, that limits the generalizability of the results of that study. Of course, we talked about patient-important outcomes. So surrogate outcomes versus actual clinical outcomes. So clinical outcomes are more important than surrogate outcomes. And of course, when you have composite endpoints, it's a matter of which component of the composite endpoint was significant. So that's important to evaluate. And of course, are the benefits worth the potential harm and cost? And this is where we look at clinical significance. So like before, like when you look at the results, you want to make sure that they are statistically significant. And then the last word is, are they actually clinically significant? And that's when you can look at cost, and you can also look at number needed to treat and number needed to harm. So sometimes the benefit, you can kind of compare the benefits versus the adverse effects or toxicities of the drugs and see if it's worth it. Now, it's not to say that the number needed to treat and number needed to harm are equivalent. So it's not to say that if the number needed to treat is um, 50 and the number needed to harm is 40, then it's too much harm. So it's not exactly like that, but these are tools to help you make a clinical decision. So here's an example of um, when you apply it to your patients. So you can see that with these treatment. So here are the two. I'm sorry. So here's the number needed to treat, calculated for two different uh, patients with different ages. So you see, for a 40-year-old, the number needed to treat is 91 versus for a 70-year-old the number needed to treat is 14. So suddenly it makes a huge difference. So if your patient was a 40-year-old in this particular example, you may choose not to use this treatment, versus in a 70-year-old it may have a more clinically significant meaning and you can use it for. So don't worry about these interventions, but this is just to illustrate the utility of number needed to treat when it comes to different patients. So in summary, we looked at when you do clinical studies, obviously you have the entire population, and when there's a new treatment, we cannot test it in the entire population. What we can do is that we can take a sample from the population and enroll them in the randomized clinical trial, and we will have inclusion and exclusion criteria for selecting the sample. And then once we do the study, we have to make sure that we have good internal validity in the study. So we look at, when you look at the two groups, you want to avoid various types of bias, such as selection bias, measurement and confounding bias. So you want to make sure that the two groups are equal. We want to make sure the study is randomized, and we want to make sure there is blinding. And by the end of the study, we want to make a conclusion, a clinical conclusion. We want to make sure that we had adequate follow-up, and then once we make that conclusion, that's where external validity comes in. So this was from a sample from the population, and the question is, can you apply it to your patient? And that's where you evaluate external validity and you look at clinical significance, and if the answer is yes, then you can choose that option for your patient. This concludes this presentation.